Hi, everyone. Thanks so much for joining us today. We're just going to give it another 2 seconds for everyone to come in from the waiting room, and then we're going to get started. Okay. I think we can get started now. Welcome, everyone, to today's webinar. The topic of the webinar is partnering with families to identify and support individuals with ARFID. And we have Drs. Thomas and Eddy today with us to present on this really important topic. And I'm really appreciative to them for being here with us today. They are truly experts on this topic. And I know that you're going to gain a lot out of the presentation. So I'm just going to start with a few housekeeping rules. The first thing is that you are admitted with your cameras off and your microphones off. You need to keep both of them off throughout the duration of the webinar, please. And if you have any questions throughout the webinar, you can just pop them in the chat box and we'll get to them at the end of the presentation. And the one thing that I just want to request is not to speak between you guys in the chat box if you're sending it to everyone. It gets really hard when I'm moderating at the end. If there's so many comments kind of between you, it's hard for me to find the questions. So please keep the chat box to all of us to questions only. And also please keep the questions relatively general. Unfortunately, they're not here to give you a consult. They're just here to speak about, the topic in general. So now I'm going to hand it over to our presenters. Thank you so much for being here with us today.
Well, hi, everyone. Thank you so much, Judy, for inviting us. Jenny and I are really glad to be here. I'm going to be showing the slides, but Jenny and I will go back and forth through the presentation. So it's really our pleasure to talk about ARFID today and really to think together about how we can partner with parents and families to identify and support folks who have ARFID. Before we get started, I thought I would just quickly give an overview of our program at Mass General Hospital in Boston in the USA. Our program's mission is to deliver high-quality, evidence-based, time-limited treatment, to conduct innovative research with clinical implications, to offer training and dissemination of evidence-based treatments and research for students, professionals, and the community, and to educate the public about eating disorders. In our program, we focus mostly on folks who are 10 and older. So we see kids, adolescents, and adults, but again, generally 10 and older. And the program provides treatments in cognitive behavioral therapy, family-based treatment, DBT, dialectical behavior therapy, psychopharmacology, and then we partner with physicians around medical care and evaluation. In the way of disclosures, I'll just mention most relevant for this talk is that Jenny and I have published a few books focused on ARFID. First is our treatment manual, the CBT for ARFID book, and then the second is a self-help book, the Picky Eaters Recovery book. Jenny's also written a couple of other books that are important, and then both of us do receive consulting fees from Equip Health. In terms of an agenda, we'll talk about how you might know if your kid has ARFID, what common parent concerns we hear, and then focus really on how ARFID is treated and how parents can be involved in supporting recovery. Now I will turn it over to Jenny.
Thanks so much, Kamryn. So I'm going to be talking about how do you know if your child has ARFID. So we can just move to the next slide, Kamryn. The first thing that I wanted to do is just validate, though, how hard it is to be a parent. I can speak to the lived experience of being a mom. I have a 5-year-old and a 7-year-old. Kamryn's also a mom, having a 10-year-old and a 3-year-old. And it's just really tricky to know how you're supposed to feed your kids. I feel like, especially in this day and age with influencers, TikTok, Instagram, we get these really mixed messages. So on the one hand, we get this message that we're supposed to make sure our child eats perfectly, that we provide them with like a little bento box of all the different food groups, that everything looks gorgeous and beautiful, and that they eat all of it. but then also that we're not supposed to pressure them. So somehow they're supposed to like magically just eat all the right foods, but we're not supposed to tell them to clean their plate or, we're supposed to not pressure them that they have to try something. So I think there are so many mixed messages, and it's just really hard to navigate this landscape. So I just wanted to start with like that point of validation. That's like the context that we're in. But regardless of how challenging it might be, to be a parent in this day and age and to have a young person try to figure out how to help them to eat, we do have this diagnosis of avoidant restrictive food intake disorder, or ARFID, that would characterize folks that are really having great difficulties with their eating around dietary restriction. And just to put us all on the same page, although I imagine that many of you are familiar with this, having come to this webinar, but the way that ARFID is defined, it kind of came to the diagnostic nomenclature in psychiatry about 10 years ago. And it is defined by a persistent failure. I don't love that term, failure, but difficulty meeting nutritional needs, causing one or more of the following problems. So it has to result in difficulties like weight loss or difficulty growing, significant nutritional deficiency like low vitamin C or low vitamin B12, low iron, dependence on tube feeding or supplement drinks, and or psychosocial impairment. And we've definitely seen really a wide degree of psychosocial impairment among folks with ARFID. I remember one time we were really lucky to have our research featured on the local news. And one of the things that the news anchor kept repeating is that these kiddos had difficulties going to birthday parties. And that could certainly be true. Your standard birthday party, they might be eating cake and pizza, and that might be really tricky for somebody with ARFID if those aren't among their safe or preferred foods. And certainly that can be a piece of impairment, but we've also seen things, that are even much more difficult than that. Like, folks that have difficulties in the workplace, they, don't eat all day, maybe because they are worried about eating their preferred foods in front of other people and being judged as childish or eating child foods. We've had folks come in who maybe have to come home from college or university because they can't find anything to eat in the dining hall that makes them feel safe and nourished. And so really it can be quite extreme. Now, of course, the restriction can't be due to a lack of available food. So it needs to be, that the person maybe has access to opportunities to eat a broader variety or volume, but they just really have a hard time doing it. And also, it's not related to a fear of weight gain or body image disturbance. So it's going to be different from the other disorders that many of us are all familiar with, like anorexia nervosa and bulimia nervosa, because there's sort of a different motivation behind the difficulties with eating in ARFID. And then it can't be accounted for by another medical or psychiatric condition. Although, of course, we're aware, and I imagine all of you were aware, being in the trenches, that ARFID can certainly co-occur with a lot of other things like autism spectrum disorder, anxiety disorders, GI type of conditions, and so forth. And typically what we see in clinical practice is that there are kind of three different presentations of ARFID, but they can overlap. So let's just think about them together. And if you're, someone who at home maybe has a young person who may have ARFID, you could kind of think to yourself if they fit into any of these categories. So the first one would be a lack of interest in food or eating. And so kind of a classic example of this is that I remember interviewing a young man, a teenager, who was fed almost entirely by tube. And so I asked him kind of what makes it tricky for you to eat by mouth? And what he shared is he said, Dr. Thomas, I don't get hungry ever. Like I just never get hungry. And I was so struck by that because that seems so different to many other people's experience where it's like here in Boston, let's see, it's 12:09. I'm wondering like, oh, I wonder what I'll have for lunch after this. I'm kind of looking forward to dinner. But this young guy, that really wasn't on his radar. He really was not feeling hungry, was not interested in food. It really felt like a chore or a difficulty for him to eat. And so, as you might imagine, many folks who have that presentation will present as kind of chronically underweight throughout their lifespan. And that chronicity of the difficulty, I think, is something that Kamryn will speak to in terms of the hard time getting help sometimes, because it's not like an acute drop like you might see in anorexia nervosa in terms of weight. Next presentation. Oh, actually, I just want to say a little bit more about the last slide, Kamryn. We're getting too excited about our cultural slide, but we'll get to. Another one would be the fear of aversive consequences. So these would be folks who maybe they've had a really scary experience with eating, like maybe choking or vomiting or getting the norovirus, having an allergic reaction. And because of that traumatic experience, they get really afraid of eating either certain types of food or eating food at all. And so really paradigmatic example for me was a little girl that Kamryn and I treated who was about 11 years old. And her parents emailed me saying, hey, our daughter just got a palate expander put into her mouth, like an orthodontic piece of hardware that made it difficult for her to chew. And about 2 weeks ago, before they sent me that email, they shared that she had choked on a pork chop. And since that day, she was really terrified, really afraid of choking. And by the time they emailed me, she was only drinking liquids like Pedialyte and water. And actually, it was really difficult for her to eat anything else. And she had precipitously dropped weight and was just really scared of eating. And then the last example would just be folks who have food selectivity because of sensory sensitivity. And these are folks who often will present across the weight spectrum. Maybe they're eating enough volume of food oftentimes, but their variety is really limited. So they might feel more comfortable just eating, like pasta or bread or rice or crackers. It's hard for them to bring on board new foods, particularly protein or fruits or vegetables. And then the last piece I would just say that kind of, it says it on the top of the slide, but at first we thought, okay, well, these are categories, we'll see people who fit into these molds. But of course, when you really dig into it and actually get to know people, what we found is that there's a lot of overlap here. So we'll see folks who have all three presentations, or maybe a severe presentation of one and a more mild of the other at the same time. So it's really, the treatment needs to be tailored to the symptoms that the person has. Now, culturally, one of the things that we have found is that folks who are in Boston, the United States, when they present with ARFID, oftentimes will be eating things that are commonly presented here, like mac and cheese or vanilla ice cream. So those might be kind of their comfort foods. But, Kamryn and I have had the opportunity to collaborate with colleagues around the world and hear from them, their ARFID patients, what they might be eating. And so, like, for example, in Mexico, our colleague Ava Trujillo said that many of her patients actually eat tortillas and Mexican cookies, which you can see there's kind of that similarity of like the carbs there, and maybe kind of that it's sort of a bland and common food, but very different foods. Tortilla, I would be really excited if I can get some of my patients to eat tortillas. But then if you go across to Europe, so if you look in the Netherlands, our colleague Sandra Molken said that many of her patients with ARFID will like to eat hagelslag bread, which I've never tried it, but it looks pretty delicious. But from what I understand, it is like toast with butter and chocolate sprinkles. And so again, this is like a really common thing that folks will be eating in the Netherlands. And so that's a preferred food often with ARFID. But I do think some of my folks that I work with would be hard pressed to try it. They might look and be like, oh, it looks kind of funny. There's black stuff on it. Then if you swoop over to the Middle East, our colleague Hala Taha in Dubai said that many of her patients like to eat white rice. And then lastly, in Australia, our colleague Copeland Winton has shared that many of her patients will like to eat something called 2-minute noodles, which seems like it's kind of like ramen noodles, maybe like a sort of a quick noodles that you can make with boiling water. So all of this is just to say that there's sort of common characteristics to foods that often feel comfortable for folks with ARFID to eat, things that are kind of bland and high in carbs. However, the specific type of food might be idiosyncratic to like where they grew up, what were they presented with, what was common in their culture. I think that that's really interesting. So, in terms of whether your child or someone might have ARFID, one thing that might be helpful would be for them to fill out a questionnaire. So our team, in collaboration with Rachel Bryant-Waugh in London, and then Nadia Macaulay in Denmark, and Lucy Cook in London as well, have created the PICA ARFID and Rumination Disorder ARFID questionnaire. It's kind of a mouthful. We call it the Party ARQ. There's a link here, and we're happy to make the slides available that you can actually click on it and find the questionnaire. There's a parent version that you could fill out about your child, and then there's a child or young person kind of self version that people 14 and up can fill out about themselves. And so what this questionnaire does is that it asks about questions that you could use to sort of screen somebody positive or negative for ARFID. So somebody with ARFID would usually score positive on this measure, and someone without would usually score negative. It goes through the different diagnostic criteria that I mentioned on the earlier slide, but in kind of a more understandable way without jargon, hopefully. And then it also asks about the different profiles of ARFID. So like for that sensory presentation, it asks things like, over the past month, have you been particularly sensitive to the appearance of food? Has it put you off eating or trying new foods? You know, things that don't look right, or they're the wrong color, or they have broken bits. For lack of interest, we might ask folks, over the last month, how often have you forgotten to eat or found it difficult to make time to eat? And then for fear, we might ask, over the past month, have you been avoiding or restricting the amount of food that you eat because you are afraid that something bad might happen, like being sick, choking, having an allergic reaction, or being in pain? Now, one thing that we found really interesting, and it would be cool to hear from your all's experience during the discussion or Q&A portion. But sometimes we're sitting with a family, so like with a young person with ARFID, and also their parents. And what might happen is that the parents might say, "Hey, we're really worried about our child. It seems like they're having real difficulty eating enough food, and they're underweight, and their diet is limited to maybe 4 or 5 foods that they feel comfortable eating on a regular basis." And then we might say, yeah, that sounds really worrying. We're worried as well. And then we might ask the young person, tell us more about what's going on. And they might say, oh, it's fine, like not a big deal. And we've seen it kind of varies a little bit across the lifespan. I would say this piece is a little more anecdotal than data, but oftentimes the younger the children are, the less maybe they see the ARFID symptoms as a problem because they're a little bit more socially normative to what other children their age are doing. And oftentimes as they get older, the difference between their type of eating versus what their peers are doing maybe becomes more salient. And sometimes they become a little bit more aware of the problems that they're having, or maybe even more motivated to change them. One of my favorite examples of this was that our colleague Helen Murray recently treated a teenage boy who one of his main goals in treatment is he had a crush on this girl and he wanted to take her on a date. And we live in Boston, so his idea of the most romantic date would be taking somebody to the north end of Boston to eat at an Italian restaurant. So he really wanted to be able to eat pasta. So we worked with him, could he try noodles, different types of noodles? Could he try sauce? And then kind of put that together. So in any case, as he got older, it became more salient. But so in general, if we look at those party ARQ scores from adults and children, we do tend to see that across families, parents who rate their children as having high ARFID severity usually also have children who themselves rate themselves as high on ARFID severity. So there's kind of some agreement there, like inter-rater agreement between parent and child within the family. However, one of the things that we did notice, which is kind of aligned with the clinical experience that I just shared you about, parents saying there's a problem and kids saying, oh no, there's no problem, is that when you look at within families, parents usually report greater ARFID severity than do the children themselves. So in this graph, we're just showing you how people score on the party. And you can see the gray bars represent the parents having all higher scores, and then the children have the burgundy or the red, and they're all scoring a little bit lower. So they're related to one another, the scores, but in an absolute sense, the parents are usually reporting more problems. And we've thought a lot about why this might be. And one idea we have is that when as I mentioned earlier, there's a lot of focus on parents. Oftentimes we are feeding our children, and so we might know the level of parental accommodation that we're doing to kind of support our child's eating. So, for the child, maybe their preferred brand of yogurt does show up on the table, and so they don't feel that impairment. They're like, okay, yes, this is the yogurt I eat, I feel comfortable, I'm going to do that. But then they don't maybe know what went into it, that maybe mom had to go to like 7 different grocery stores to find the right flavor and the right brand, and just to make sure that their child would eat. So we do wonder if maybe the level of parent accommodation might be so high that the child's insight into their impairment is kind of limited. And then when that burden gets passed on as they get older into adulthood, they might realize more how big of a deal this ARFID is. And so we just wanted to share a couple of examples of different ways how ARFID can kind of impact families, and that parents might find that they have to change their own behavior just to make sure that their child would eat. And so I want to clarify here that we're not trying to be critical or anything in any way. Like, our perspective is that, hey, parents are doing what they need to do. I definitely will raise my hand and say, I have for sure made a special meal for one of my children at dinner time, like just so that they would eat. But we're just kind of naming what we've seen often will happen in households where, you're just desperate to try to get your child to eat something. So you're going to try to give them the foods that they're going to agree to eat. So things like making a special meal, driving to several grocery stores to get the preferred brand of food, maybe only going to restaurants that serve preferred foods, bringing special food to events like family holidays, maybe packing a full suitcase of supplement drinks for a trip, maybe driving 2 hours to the nearest preferred pizza restaurant to kind of stock up on pizza for consumption during an international trip. And our philosophy here, which we'll speak to a bit later, is that early in treatment, you probably need all of these accommodations. Like, you need to be able to help the child just eat when they prefer. But over time, hopefully in treatment, what we can do is address to try to help the child eat more food, or the adult kind of more variety or volume, so that these accommodations are less needed. I think I think the other thing too, in terms of separating ARFID from normative picky eating, is just the idea that picky eating is pretty common across the lifespan. It tends to be really highest between ages 2 and 6. But what we find is that there are some kids that do not grow out of this picky eating phase, and those are the ones that we're kind of more worried for ARFID. And I'll just share, on a personal level, I feel like I definitely experienced this when my first son was born, when he was like maybe 6 to 12 months and he was just starting on new foods. I remember he was really adventurous and would kind of eat anything. And I was all smug thinking like, oh, it's probably because I researched ARFID, he's such a good eater. But guys, as soon as he turned 1.5, 2, he really, went pretty picky, just like it shows in this graph. And he wanted mac and cheese, he wanted nuggets. Luckily now he's 7, so he's a little bit more on the other end of it, and will eat a variety of things. But I think it just, kind of goes to show that like this, it can be tricky to do that differential when kids are really young, because they're with peers maybe who also have similar eating habits to them. So individuals with ARFID, as kind of shown in that graph, usually their picky eating is not going to improve on its own. And so just before I turn it over to Kamryn, I'll just show you briefly. We do have a study recently published where we followed folks with ARFID for a 2-year period, just to look at what would happen to them. So some of them received treatment and some not. We just studied it from a naturalistic basis. And what we found is that at the 2-year follow-up period, about half of folks still had full syndrome ARFID at that time, so they didn't remit. There was another, and that's that red part of the graph. And then you can see in the orange that there was another quarter that improved. So they developed subthreshold ARFID, so they kind of still had difficulties, but maybe not at the severity as they had before. And there was a quarter that actually did fully remit. So that was really promising as well, that, some of them were getting better, but obviously we'd rather they all get better. And one thing too, I'll point out just in that little tiny blue piece, is that there were 3 individuals who did go on to develop anorexia nervosa over time. So we're really interested in trying to prevent that outcome, of course. And then last bit is, luckily the optimistic piece is that whereas the naturalistic outcome might be that maybe a quarter get better over a 2-year period, with treatment, what we've seen in our early studies is that closer to 2/3 or 70% will remit following treatment. And these are outcomes from our preliminary cognitive behavioral therapy for ARFID study. It's a 20 to 30 session treatment that we'll describe in just a moment. And you can see that the outcomes were pretty favorable, with, again, more than 2/3 remitting. Folks added about 16 new foods to their diet, increased their weight by about 11 pounds, and both parents and children reported major improvements in their ARFID severity. So we were happy with that, and we're following up the treatment to improve it, and doing a randomized controlled trial now, comparing it to another comparison treatment. I think now I'll turn it back to Kamryn.
Thanks, Jenny. So, I think Jenny's talked a little bit about how do we recognize ARFID? What does it actually look like? What I thought I would share, just in brief anyway, are some of the most common concerns that we hear from parents when they first come in for treatment. So the first is, this question of, am I making too big of a deal out of this? My pediatrician says she'll just grow out of it, but I don't see how. I spoke just the other day with one of my young adult patients who is doing very, very well, but who describes that, both she and her mom recognize, she less so, but her mom recognized even in utero that she was a different eater than the other child. That, even in utero, mom was having a harder time eating fruits and vegetables because the baby was kind of having a reaction to those even in utero. And that then throughout this child's life, she was having a very difficult time eating. But that when mom went to the pediatrician kind of again and again and again, the message that she would get was, she'll just grow out of it. This is not a big deal. And one of the things that felt really important to this family and feels important to underscore here is the idea that parents really do know their kids. They have this experience, they know what's happening, and often they can kind of figure this out early on, even before the doctors do. This led to, and I am sorry, I can't see my own slides. This left to this feeling on the family's end of feeling really alone, and also feeling as though what was going on for their kid wasn't seen as an illness or recognized as such. One of the other things that folks will describe is, everyone around me, my own parents, fellow parents, moms and dads will say, just make them eat. If that were my child, this would never be happening because I wouldn't tolerate this kind of behavior. And that kind of experience is incredibly shaming. It feels really judgmental. And it's a real misunderstanding of ARFID as an illness. In the same way that people wouldn't choose to have anorexia or wouldn't choose X, Y, or Z to make their lives difficult or their families' lives difficult, folks with ARFID are certainly not choosing this. And it's not the fault of parents. Relatedly, people say all the time to us, is this my fault? Everyone else's kids will just eat. Why can't mine? What am I doing wrong? And again, the sense of self-judgment, a real anger and frustration, sometimes at the self and sometimes at the kids, it is really challenging and also incredibly common. This is something that we try really hard to mitigate when folks first come in the door, because feeling as though you've done something wrong certainly doesn't position you to help kind of partner with your kid to move forward. And yet it's a really common experience that people have coming in. One of the other things that we see is some families and some parents will describe, this is how I was as a kid too. And so this is, it's this experience of sometimes feeling like ARFID does run in families. Sometimes parents will have had an experience of being picky eaters themselves. Sometimes they will have gotten better in time. Sometimes they will have gotten better with treatment. And sometimes they might still be a picky eater. This experience can sometimes be a positive one in the sense that it makes them empathic. They understand what their kid is going through, and they understand and can relate to actually just how difficult this is for their kid. But it also can lead to this sense of helplessness, feeling like, I don't know what to do. I didn't know what to do as a kid, and I don't know what to do now. And then for others, it may even lead to minimization of the problem, feeling like, well, this is just how I was as a kid, and I'm okay now. I'm sure that my child will be okay too, which may be true for some, but may also minimize the real experience of what this is like for somebody with ARFID. One of the other common things that Jenny and I see in our clinic is that people will come in after having done a lot of work. So folks will sometimes come in and say, my kid has been in feeding therapy. I've been doing this for 4 years, for 5 years, and I feel like we haven't had any progress. There's a lot of different approaches to the treatment of ARFID, and we'll share with you ours. But they can be very variable in the sense that some are really no pressure, some are more active and more directive. And if you have had the experience of being in treatment for a long time with no progress, understandably, it can lead you feeling helpless and hopeless. And so what we try to do is really frame that we have a different approach here that is more active. Now I'm going to pass it back to Jenny to walk through the treatment model that our program uses. And so I'll pass it to you, Jenny.
Thanks, Kamryn. So we wanted to share our model of how we think all the ARFID symptoms fit together. And it starts really with having a biological predisposition. So we won't get into all this detail today, but we're happy to share more if anyone's interested. We do a lot of research looking at appetite regulating hormones. We found that they're actually quite different in folks with ARFID versus healthy controls. So folks with ARFID, just by way of example, will usually come into the laboratory in a fasted state and have actually higher levels of cholecystokinin, which is a satiety hormone, in a fasted state. So it's almost like even though they haven't eaten yet, their body is telling them they're already full, which is super interesting. We've also seen some differences in the degree of sensory sensitivity perceived around taste or smell between folks with ARFID and healthy people, or healthy, like non folks without ARFID. And then we've also seen some differences in the brain in terms of neurobiology. So by way of example, folks who have that presentation of kind of being afraid of food or choking and vomiting actually show greater activation in the brain's fear regions when they're just looking at pictures of food versus people who don't have ARFID. So we really, again, believe no one would choose to have this illness. No families are choosing for their child to have it. We think really there's just a different biology that kind of sets people up to be at risk for this. And that in that context, folks may have a food-related trauma like choking or vomiting or anaphylaxis, which then like heightens, kind of the really capitalizes, leverages this biological predisposition, although that doesn't always happen, but in some cases. But in either way, it's going to lead the person to have negative feelings and predictions about the consequences of eating. So, what this means is folks with sensory sensitivity might think, okay, all new foods will taste disgusting. I tasted broccoli, it was terrible. So I'm going to generalize that to asparagus, carrots, any other vegetables. I'm certain they're going to be terrible. For fear aversive consequences, somebody might have a really bad experience with norovirus, have to go to the hospital, get IV fluids, and then they never want that bad thing to happen again. So they think, I'm going to probably vomit after anything I eat. I better be super careful about what I'm eating to make sure I'm going to prevent that from happening again. And then lastly, folks with that lack of interest in eating might think, okay, whenever I eat, I feel full, I feel nauseous, I feel uncomfortable. I think eating will always be uncomfortable and unpleasant. It's never going to be something that I can look forward to. And these feelings and predictions can lead to consequences, of people obviously avoiding certain foods, restricting their eating, and then that can lead them to nutritional compromise, like losing weight or having vitamin deficiencies, which then kind of feed back onto increasing avoidance and restriction because, if they're low weight, their body gets satisfied on less food. And so it kind of just makes things worse. If they get certain nutrition deficiencies, like a zinc deficiency, can make food taste different. So it then makes it even harder to eat. And then, of course, it can lead to psychosocial impairment, which itself includes more limited opportunities for exposure. So if your whole family starts to get the feeling that, you can only eat 3 or 4 foods, they're not going to invite you out for different types of cuisine or propose that you try new foods. You kind of get in this really small food world that just reinforces the problem. And so what we try to do in CBT for ARFID is really an exposure-based treatment where we try to create exposures to food and eating related situations that the patient is avoiding to try to help them to create new learning. So for folks who have sensory sensitivity, we just try to have them try a bunch of foods that they themselves choose and select. So not their parents, although parents can give suggestions and input, but the young person will pick what they want to try. And what we want them to do is just try a bunch of things, like throw spaghetti against the wall and see what sticks, and hopefully learn that some foods actually will taste okay. Not everything, but there may be a subset that are acceptable. For fear, we want folks to actually try a bunch of the foods that they think might make them vomit and actually have some new learning that vomiting is pretty unlikely, or that if they do vomit, that they can cope with it and that it will be okay. And then for lack of interest, we want folks to kind of realize that eating can be tolerable, like they can get through some of these tricky sensations, and that there might even be some instances, like when they're quite hungry or it's a preferred food, that it could even be enjoyable and fun. Oh yeah, and that's just our model showing how what we hope is that then there's the cascade of, by really intervening on the negative feelings and predictions about eating, that it can result in reduced food restriction and avoidance, reduce nutritional compromise, and reduce psychosocial impairment. And in terms of for whom our treatment is appropriate, I should say that our treatment, cognitive behavioral therapy for ARFID or CBT-AR, is an outpatient treatment that's meant to help children, adolescents, and adults who have a diagnosis of ARFID, who are able to cognitively engage in treatment, so they're ages 10 and up. And if they have, developmental disorder or autism spectrum disorder, that's totally fine as long as the level of symptoms is such that they're able to still, chat with us, kind of think about their thinking, engage in metacognition. They need to be eating by mouth, so not requiring tube feeding, because otherwise we would recommend a more of a tube feeding structured protocol, tube weaning protocol before they could do this treatment. And they need to be monitored by a physician because obviously ARFID can have serious health consequences, and patients are at risk for refeeding syndrome. And for most children and adolescents, and even young adults who are living at home, the involvement of parents is totally critical, and we'll talk a little bit more about that. In terms of the 4 stages of CBT-AR, we always start with psychoeducation and early change. So we share a lot of the concepts and ideas that we've just shared with you, and then invite folks to make changes right away. In stage 2, we work on treatment planning, so figuring out which ARFID mechanism we're going to target, figuring out which food somebody might like to try in treatment. And then in stage 3, we really go in on all those exposures, and we do them a little bit differently depending on whether somebody has sensory, fear, or lack of interest. And we'll give you some examples in a minute. And then in the end, we work on relapse prevention and kind of solidifying the gains that the patient and family have made. I had mentioned earlier the idea of the parental accommodation, and I would say our stance on that is that it really is going to vary by the stage of treatment. So in stage 1, really we're focusing on volume, like trying to help folks just get enough to eat, even if it's just their preferred foods. And so probably we need to just keep in place those high levels of parent accommodation to just achieve regular eating. So, if your child will only eat one kind of yogurt, like please go to the store and get it for them, because otherwise they're not going to be eating. So I think, trusting your gut, we trust you as the parents to help us figure out what to feed them in terms of what they'll prefer. However, as we get to the later stages, like stage 3 and 4, we try to partner with parents to kind of gradually reduce the accommodations to expand variety. So like if there is a food that's really tricky to track down, maybe that would be a first place to start of different variants of that yogurt that the child might be able to accept, or different types of pizza that could be okay, or could it be okay to reheat the same pizza that was purchased prior, for example. And then ideally at the end of treatment, we want to leave the family with only the accommodations that are reasonable for the family to keep doing and that they feel comfortable with their child. Now I'll pass it back to Kamryn.
Thanks, Jenny. I'll walk us through stages 1 and 2, and then I'll pass it back to Jenny. So in stage 1 of treatment, what we do is a lot of psychoeducation with a real focus on encouraging early change. So you've heard a little bit about our psychoeducation already based on what we've shared about our thoughts on ARFID and our research on ARFID. We talk with folks about understanding ARFID as an illness and not as a choice. From day 1, we're encouraging early change in volume or variety. We think about individuals with ARFID, based on what your own experiences have been, and certainly also based on what we've talked about today, as folks restricting or limiting both the volume of food that they eat, meaning that they're not eating enough quantity, and also the variety, so that they're limited in terms of their range of foods. Some people have both difficulties with volume and variety, and then some folks will have problems only with one or the other. For folks who are underweight, almost always they're limited in volume, kind of by definition. They're not eating enough volume of food in order to gain weight. And so the first change that we advocate for them to make is really in volume, increasing the volume of food that they're eating to really promote weight gain. For folks who aren't underweight, often what we're doing for them is helping them to increase the variety of food that they're eating at this point, really from the beginning, to try and jumpstart change. Some of the things that folks can do from the beginning when they have a limited variety is to make any kind of small change. So maybe they're eating the same kinds of foods every day, but they're having one typical lunch and then one typical dinner. Maybe we'll encourage them to kind of switch those up so that they have the dinner food for lunch and the lunch food for dinner. Maybe there are some foods that they only have on the weekends. Maybe there are some foods that they've recently dropped, like that they, were on a food jag of eating toast and jam, and they were doing that a couple months ago. Now they don't have that at all anymore. Maybe that would be an easy food for them to try bringing back in. Sometimes when we ask folks about what kinds of foods they eat, we'll have kids especially who do describe, yes, no, I do have fruit, or yeah, no, I would eat that. But then when you look carefully at their food records, it turns out that it hasn't shown up in their diet in the last couple of months. But it is something that maybe they would eat if it were around. And so that would again be, I guess like kind of so to speak, like a low-hanging fruit that would be worth bringing back in to try out now. In the beginning of treatment, we also advocate for self or parent monitoring. And this is to give folks a better sense about what's actually happening with their eating. Are there patterns that we notice? And then, really importantly, can we start to help them track the patterns that are changing? So, if they're increasing volume, if they're changing up their variety, can we help them to notice that and pay attention to it so that they can give themselves credit for it and then begin to build on it as well? We ask folks to do regular eating. And in stage one and throughout treatment, regular eating usually looks like breakfast, lunch, and dinner, and 2 or 3 snacks kind of spliced in there. And by regular, what we mean is eating at the same times every day. The idea for that is not to promote rigidity. It's not that we're trying to be dictators in the way that people eat. But the idea is that appetite regulating hormones do have a natural cycle to them. And we want to help them learn that their bodies can get used to eating more at a different time. So for folks who have ARFID, often they're not eating enough during the day, or their eating may be erratic. We want to help promote sort of normative hunger and fullness signaling. And one of the ways to do that is actually by helping people to get on a regular pattern of eating. Taking all of these data together, we help folks come up with a personalized formulation. That formulation looks a lot like what we just heard Jenny describe in the cognitive behavioral therapy model, but it's really using their own language. So I'm trying to understand what their particular symptoms are and then how their constellation of symptoms fit together so that then we can help them understand why and where we'd want to intervene to help the whole thing kind of come apart. This is an example of one of the psychoeducation pages for us. What we walk through is, what does ARFID look like? We talk about the 3 different presentations. Again, as Jenny said, they're not unique presentations. So it's not as though, somebody will have sensory and then they don't have any fear or they don't have lack of interest. They may, but a lot of times these are overlapping. And so we're presenting everybody with all of them so that they can talk a little bit about what resonates for them. What are they seeing and what are they experiencing? And then helping them to recognize that ARFID patterns of eating are not a choice, but instead it's an illness that they can actually make changes to get better from. We see parents as a key partner in recovery from eating disorders. In cognitive behavioral therapy for ARFID, rapid change is expected from day one. We want folks to jump in by making some changes. And so I've shared with you guys already, for underweight folks, we're talking about increasing the volume. And for non-underweight folks who generally are more likely to be limited in variety, we're helping them to make some small changes from the beginning. One of the questions that we get a lot is for folks who are underweight, how do we help them to gain weight? In people who have ARFID, who may have always been small or always been underweight, we're a little bit less likely to see the sort of sudden fall off in weight that we see in patients with anorexia nervosa, for example. And so more often, these are folks who have always been small, who have always been lower on their growth curves. And so we're asking them to make a lot of changes, and that can require a lot of psychoeducation too, a lot of thinking together with families about what those changes could look like. So here are just a couple of examples that we think about. One of the things that is often true, for folks with ARFID is that their preferred foods are often foods that, if they were able to eat a big enough volume of, they actually might help them to gain weight. And so what we're encouraging is larger volumes of their preferred foods. And so this is going to harken back to what Jenny said a couple minutes ago around accommodation. The first thing we're going to be doing, is supporting the foods that they're already willing to eat, but just bigger volumes of them. So that's definitely an accommodation that we're going to support and want to keep making, because we want them to take in the foods that they're already willing to do and just have more of them. I'm going to move to stage 2. And I guess I will just say too, the big caveat here is we're giving you guys like a high level overview of the treatment. There's so many details, and I'm sorry we don't have the time today to go through all of it. But again, we're happy to share our slides and happy to talk more. In terms of stage 2 is brief. It's really around treatment planning. So we've done the psychoeducation, we've helped them to start to make some changes in volume and variety in their eating. And then stage 2 is really planning. What are we going to do in stage 3? Stage 3 is the heart of the treatment. That's where we're doing all the exposures. Jenny's going to talk about it in a sec. So in stage 2, we're planning for that. Okay, now we have a good sense about your ARFID. Where are we going to go and what do we need to do next? One of the things that we do in stage 2 is we do very careful understanding of people's eating. We look at a long list of foods, and we also have them map out kind of what their day-to-day food looks like. In a recent study from our team, we looked at 104 kids, 9 to 22 years old, who participated in a cross-sectional, it was a longitudinal, but non-treatment study of folks who had ARFID. These were people who had full threshold ARFID, and then some other folks who were healthy controls, full or subthreshold ARFID and healthy controls. And what we did was look at the constellation of their diet, kind of day to day. What I'm going to show you first is the folks who are healthy controls, what their day-to-day diet looked like. So this is actually the My Plate. If you're from the States, you may be familiar with this. ChooseMyPlate.gov. It gives you kind of an example, healthy kind of expectations for growth, what your diet, I would say in quotes, but should look like. And that is kind of these 5 areas. So 4 quadrants plus dairy, fruit, grains, veggies, and proteins. And actually what we found here is the representation from the healthy controls was actually pretty good. We were pretty impressed by how they were doing. They were having grains, proteins, veggies, and fruits, and then they were having dairy. And they were pretty close to what the expectations were. By contrast, for our kids with ARFID, their diets looked a little bit different. So they were better represented in the grains and in dairy, and they were definitely struggling more with fruits and vegetables and proteins. And this feels really consistent with what we see clinically, and I wonder if this resonates for you guys on the phone, on the Zoom call today as well. But is that what we see is that fruits and vegetables and protein foods are often much more challenging for our folks with ARFID. Doing a map like this for in treatment helps then to set us up for what are we going to do in stage 3. It helps to say, okay, it looks like fruits are underrepresented, veggies are underrepresented, and proteins are underrepresented. So those might be some key categories that we want to help you grow as we move into stage 3. We have them walk through what we call the building blocks, which is a quite long list. It's about 10 pages of individual foods that could go into a mixed dish, but that often could also be eaten solo. What we're asking folks to do is to indicate, are these foods that they're already comfortable eating? So are they already eating it? Or if they don't eat it like every day, they would be totally comfortable if it were in front of them right now. And then we have a very low bar for, are they willing to learn about it? The language here is really intentional. It's not, are you willing to eat that? You're going to eat it and it's going to become a new food that you eat all the time. But instead, it's really, are you willing to learn about it? And taking a pretty neutral stance. Is that something you'd be open to talking about? And we have them go through this long list, again, encouraging them with the idea that there are so many different ways to get your nutritional needs met. And, there's nothing magic. Jenny used the example earlier of somebody having broccoli and then being totally turned off from vegetables. There's nothing magical about broccoli. It's a great vegetable, but it's not the only one. There's so many different ways that you could get those particular nutrition needs met. In this, the child takes the lead in deciding which foods they're open to working on, and then the parents can take the lead by actually getting and preparing those foods. Now I'm going to pass it over to Jenny, who can walk through the types of exposures that we do for stage 3.
Thanks, Kamryn. So the main thing that we focus on in stage 3 of the treatment is exposure. And really we try to leverage the support of parents to really facilitate successful exposures. So things that we ask parents to do is just to supply the food for the exposures. Sometimes we're on a Zoom call with a family and, the young person is trying food at a table where the computer is to talk to me, but then, parents are in the background scrambling up some eggs or heating something in the microwave to try to help with that. And also just modeling some calm approach behavior, when the child is really nervous, maybe about trying these things. So the way the exposure looks is a little bit different depending on the type of ARFID presentation. So if somebody has sensory sensitivity, what we want to do is help them pick foods to learn about from that long list that Kamryn just showed to increase representation across those food groups. And we might particularly focus on areas where they're missing things like fruits, vegetables, and protein, foods that might correct nutrition deficiencies. So like if they have low vitamin C, we want to definitely, hopefully they can be put on a supplement for that in the short run, but in the long run, we want them to be eating more vitamin C rich foods. We also want them to think about foods that might help reduce their psychosocial impairment. So if they are having a tricky time going to birthday parties or sleepovers as, really younger kids, then trying to eat pizza could maybe be really beneficial for them to be able to socialize. So we start in early sessions with repeated exposure to very small portions of food. So we just ask them to answer 5 questions about, we have them bring in 5 foods to each session and to ask themselves 5 questions about it. So, using neutral language though. So what does it look like? What does it feel like? What does it smell like? What does it taste like? And what's the texture like? And if they say, it smells disgusting or it looks terrible, we'll redirect them to think about, okay, does it smell like another food that you know? Does it look green or round? And just really keeping it kind of neutral. And then at the end of that process, we'll ask, hey, is this the food that you're willing to continue learning about? And then if so, they'll go home for homework and kind of practice eating that food in small portions. But they're also fine to say, no, I don't want to continue with that food. And that's okay. That's why we bring so many foods to each session. Everyone has likes and dislikes. But the hope is that over time, they'll pick several foods that they are willing to, what we say is incorporate larger portions into meals and snacks to actually meet their calorie needs. So rather than just having like 1 or 2 grapes as a taste, they might have a handful of grapes as part of their lunch, for example, as an incorporation. Then when we think about the folks who have that fear presentation, we really try to help them understand how the more they avoid a certain food, even if they're afraid it causes vomiting or choking, the more it actually makes them afraid of that bad thing happening and kind of the worse it makes it. So we help them to create a hierarchy with kind of small steps leading up to that really scary situation that led to their initial avoidance. So I gave the example of the young girl who choked on the pork chop. Pork chop would definitely go at the top of the hierarchy. The bottom of the hierarchy would have the things she was already drinking when she came in, like water and Pedialyte and milk. And then we kind of went little by little, increasing the kind of texture of the foods until we could get to the pork chop. And every time we had her eat it, we would have her test the hypothesis. How likely is it that I think I'm going to choke on this? And then after she finished it, we would say, okay, so what happened? Like, did you choke? Are you okay? Do you think you could do this again? And so on. So in that version, the fear version, we really do more of a hypothesis testing type of approach around the feared consequence. And then lastly, for our folks who have that lack of interest in eating, we kind of try to get at it from 2 ways. So one would be from kind of what we call a homeostatic perspective, or kind of a perspective about them feeling full or feeling nauseous. And so we actually do some interoceptive exposures. So the other exposures to food technically are called exteroceptive because they're exposures to things that are like outside of your body and outside world. But here we do some exposures to things inside the body. So exposures to increased tolerance to physical sensations. So we might have folks rapidly drink several small glasses of water, or push their belly out for 30 seconds, or spin around in a chair, and then have them see that actually they can experience some of these sensations like fullness or bloating or nausea. And they're not ones that we all like, they're kind of uncomfortable, but that they can cope with experiencing that, and it's not going to last forever and it'll go away. And it's also not specific and unique only to the food context, so that they'll be okay. We also help them do a little more self-monitoring to kind of think to themselves like, how hungry am I right now? How full, to kind of get more in touch with those cues. And then lastly, just to tackle that hedonic aspect, we try to help them within session practice to highly preferred foods. So we'll say like, let's bring in some of your favorite foods, things that, maybe something special that your grandmother makes, or, birthday cake or cookies, some special recipe that's associated with a holiday, and then actually eat and really savor and enjoy those foods. Um, and the other thing that we sometimes will do is that sometimes it's really tricky for people to engage in these exposures. They're not the easiest thing to do. And so sometimes it can be helpful for parents to think about rewards or reinforcers to help the child, really be rewarded for the hard work of doing those exposures. So just a few principles here, if this is something that you're considering. Obviously, we want to pick rewards that are actually reinforcing, like something that the young person likes, and that might be pretty specific to that person. The reward should usually be immediate rather than delayed. So rather than saying, oh, we'll go on a vacation, or you can do a sleepover next month if you do well, it should be like, I will give you, 10 more minutes of TV time right after this taste of food. Or I had a patient who she had her own YouTube channel for like makeup tutorials. And so she and her mom went to the Walgreens and bought a bunch of little makeup things. And so she got like a new eyeshadow or something after each of the things that she tasted. The other thing is that you want to fade the rewards out over time. So maybe at first you're really reinforcing like a small taste of grapes. But after a while, we should fade out those rewards, and maybe the person has to have a whole portion of grapes to be able to get that same reward, because they're kind of in a more advanced state. Or maybe no more reward for grapes, but we're going to reward trying carrots. Sometimes parents will be sort of hesitant about whether they want to do a reward system. And of course, you should trust your own parenting gut on that. But one thing we try to do is remind ourselves that, hey, all of us who have jobs are paid to work. So even if we like our jobs, we do get some reinforcement from it other than just the value of it. And we do think of rewards as being different from bribes. So bribes we would think of as giving someone a reward for doing a bad thing, like a judge for, throwing the court decision, whereas a reward is giving someone a good thing for doing something good, like their therapy homework. All right, and then lastly, we end the treatment. We're almost going to wrap up, and we're excited to see all the activity in the chat and the questions. But at the end of the treatment, we try to help parents and patients to reevaluate their progress and to co-create a relapse prevention plan. It may be that your child will still need your support to maintain progress, like reminders for regular eating or continued rewards for practice. And we definitely want to keep an open dialogue about progress over time. And the other thing is that we try to leave folks with the goal of becoming lifelong food learners. And Kamryn and I have reflected that some of our favorite foods that we like now, we actually didn't even try them until college or graduate school. So we want folks to have an openness to trying new things above and beyond just during the treatment context.
Thanks, Jenny. And I will just quickly highlight for everybody, our team, we have a big team who works incredibly hard, and we like very much to partner with folks in the community. And one of the ways that we do this is by doing our research studies, so that it helps us learn more and then be able to do more good work. Two of the studies I'll just quickly highlight are, the first is our Counteract study. And this is actually a cognitive behavioral therapy for ARFID treatment trial. So for folks who are interested in learning more about that, that's Counteract. And then another study that we have going on right now is our REACT trial, which is also a treatment study for folks who have missed periods and eating disorders. You're welcome to take a look at both of those. Finally, I would just say, we want to hear from you. So what do you feel as parents and carers should be top priorities for research for ARFID going forward? We'll kind of leave you there with that question, and then we're happy to take any from the audience.
Thank you. This was an amazing, amazing presentation. You covered so much ground. Unfortunately, we are actually at time. But I know that there's questions in the chat. So what we're going to do is we basically are going to, first of all, the slides are generously going to be offered so you guys can see all the resources in it. So you'll be able to get a copy of the slides. That's the first thing. The second thing is that we have a copy of the chat, and we know all of you who registered for this webinar. So I'm going to speak to Drs. Thomas and Eddy after this webinar and try to figure out, brainstorm together, how can we answer these questions? And maybe we need a part 2 at some point, because there are so many questions. And I know that a lot of you out there are parents, and you really did kind of want answers. So I apologize that we ran out of time, but I promise you that we will come up with a solution that does get your questions answered. So that's the first thing. And I just want to finish by saying that, you know, at F.E.A.S.T, all of what we offer is free of charge, and anything that we do charge for, we offer an option of, you know, not paying at all. So the only way that we can continue offering all of our resources for free is through the support of people in our community. So if you enjoyed today's webinar, if you benefited from it, if you can give a donation, please go to our website and do so. And I also just wanted to invite everyone back. Our next webinar in October is actually a very different format. We've never done anything like it before. It is exclusively in Spanish. I'm not even going to give you the title because I'm going to butcher it, even though I did have like 14 years of Spanish. But Dr. Eva Trujillo is an amazing presenter. She's incredibly well regarded in the eating disorder world, and I'm sure it's going to be an amazing webinar. If you know of people who would really benefit from a webinar in Spanish, please pass it on. I really want to get a lot of attendance. I know we have a lot of families out there who struggle with English, and the idea really is to give people resources in a language that they're comfortable with, that they can understand. So I'm not even moderating it. It'll be moderated by one of our Spanish-speaking volunteers. And I'm really looking forward to it. It's kind of a pilot to see if we can get enough people into webinars in other languages, but it's something that I really want to do often, because I think it's so important to level the playing field for all the families out there who really don't have English as their first language and who really deserve the same access to world-renowned experts as everyone else in their own language. So thank you again, everyone, so much for coming. Thank you, Jenny and Kamryn. This was, you know, I always feel like I have holes in my knowledge when it comes to ARFID. You know, I feel like I know a lot about other eating disorders, and ARFID always just, I'm never 100% confident, and I learned so much. And I saw from the chat that a lot of parents here are parents of kids with ARFID. I'm sure they learned a ton. And as much as we covered, there's also a lot we didn't cover. So let's be in touch, and we'll figure out a way to cover all the questions in the chat. But thank you again, everyone, and have a good rest of the day.
Thanks, everyone.